During the fellowship year, we focused on critical care, specifically the intensive care unit, and identified that there were patients that had breathing tubes in that were being given these really nasty, heavy narcotic drugs, and they were causing a lot of downstream complications. So what we came up with as a need statement was a way to reduce or eliminate the use of those heavy narcotics in patients that have breathing tubes in the ICU.
Intravenous sedation as a class of medications are some of the most harmful drugs in use today in our intensive care units, though. It's been identified in several well-done studies that these are associated with some of the biggest ticket hospital-acquired complications, including ventilator-associated pneumonia, pressure ulcers, muscle weakness, which can add 6 months of rehabilitation to a stay after their acute illness, and a whole bunch of other complications that are really terrible for somebody to have to deal with when they're already in a critically ill state.
Clinical literature is everywhere. Google Scholar, LexisNexis. I mean, there's a lot of ways to go find literature now, especially when you're inside a university environment and you have access to every medical journal at your fingertips. It's very easy to have information overload in a sense because there's so much good stuff out there.
And also within the hospital itself, I think it's important to not just talk to doctors, and particularly in a multidisciplinary care area like an intensive care unit, that you're talking to nurses and respiratory therapists who are ultimately seeing the patient far more hours in the day than the physician does, and therefore are able to recognize and give you some really powerful insight as to what the underlying causes and underlying drivers of the unmet need are. I think one of the issues when you're approaching this and talking to people who deal with this every day is that it becomes the norm, and it is just normal that people are receiving these medications. It's normal that this is the way we manage it, and we don't often go a few layers deeper to think about exactly why. It's just the way it is. So that was one thing that was really important to us, is to ask people why they thought sedation was needed, to look into the literature at patient satisfaction surveys and learn more about their experience in intensive care units, and to think about the reasons why they need the sedation.
As well, there's looking in treatment areas that are adjacent to the problem you're trying to solve. There's insights to be gained. So for instance, in our case, we noticed that a patient with an endotracheal tube in was sedated, but in the room next door, there was a patient with a tracheostomy tube that was not sedated. And they were both ventilated, both critically ill, but that difference just really stuck in our minds. And then, sometime later that week, we happened upon a bronchoscopy procedure where they stick a fiber optic camera down your lungs and look at different items, do biopsies. And in that procedure, those patients were generally, not sedated. They had a little bit of sedation on board to help with the nerves, but they were otherwise awake. And they went home the same day after about a 30-minute observation period after the procedure. So it was a very different kind of spectrum of patients that all had a very similar thing in common, which was there's this foreign object going right through their throat, like having a snorkel shoved down your throat. And the difference between how each one of them was treated was really the key to understanding our innovation and how we kind of eventually came to design the Wishbone device.
It was primarily recognizing that the tube was the primary driver of discomfort, and that a one-time application of an anesthetic locally to in another patient circumstance, in another clinical circumstance, was effective on a short-term basis. So thinking about ways to make that a continuous solution really informed that decision. We did go a fair bit into the ear, nose, and throat literature. We understood the nervous system anatomy, things that sort of the nerves that are responsible for the gag reflex, for sensation in the upper airway. We had to do a lot of review and make sure that we understood exactly what was going on from an anatomic perspective to inform our solution.